Hello and welcome to today's webinar, Managing and Treating Psoriasis with Topical Therapy. My name is Bev Bromfield and I'll be your moderator for today's presentation. Before we begin, I'd like to acknowledge our sponsors, Bausch Health Foundation, Celgene, and Novartis for their support of the Psoriasis Guidelines webinar series, of which this webinar is part of. Look for the next guideline discussion about systemic non-biologics to occur on October 15th. To help guide you in how to participate in today's event, we've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during the Q&A session with today's speaker, dermatologist Dr. Laura Ferris. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. For over 50 years, the National Psoriasis Foundation has served the more than 8 million individuals in the U.S. living with psoriasis and psoriatic arthritis. Founded from a tiny classified newspaper ad in Portland, Oregon, the NPF mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. After completing one of the most ambitious strategic plans in its history, the National Psoriasis Foundation launched a new 5-year strategic plan on July 1st, 2019. With a continued focus on a life free of psoriatic disease and its burdens, NPF remains committed to finding a cure for psoriasis and psoriatic arthritis while supporting individuals to live longer and healthier lives. Over the next 5 years, NPF will focus on achieving 3 goals to lead collaborative transformational research in psoriatic disease, increase the lifespan and health of individuals living with psoriatic disease, secure the human, technological, and financial resources necessary to achieve NPF's mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. A few of the many ways that NPF supports the goal of leading collaborative transformational research include, to date, NPF has funded over $24 million in grants and fellowships. That includes $3.27 million in grant and fellowship funding announced this summer. NPF grant mechanisms support all stages of research and careers. Our research focus is on areas of unmet need and are often conducted in partnership with research stakeholders with whom we collaborate. In addition to funding outside grants and fellowships, the NPF also leads research initiatives such as the Psoriasis Prevention Initiative and the Psoriasis Arthritis Diagnostic Test Grant, which are new to the Foundation. The Psoriasis Prevention Initiative was developed at the recommendation of the Psoriasis Prevention Initiative Steering Committee. At their recommendation, we were urged to define prevention to better guide the proposal development, and that's how it expanded to disease relapse and comorbidities. NPF plans to invest $6.5 million over 5 years in this effort. The second initiative is the Psoriatic Arthritis Diagnostic Test Grant, which aims to develop a diagnostic test for psoriatic arthritis. This could significantly reduce the time between onset of symptoms and a diagnosis. This is important because we know as little as 6 months of delay between onset of symptoms of PSA and start of treatment can lead to permanent joint damage. This slide highlights 4 NPF research efforts that you can be part of. Launched in 2015, the NPF Corona National Psoriasis Patient Registry is the largest independent observational registry of psoriasis patients in the United States. The registry collects and studies patient health information, allowing researchers to compare the safety and effectiveness of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. There are currently more than 11,915 patients enrolled at more than 270 sites across the country. Your dermatologist may be enrolled as an NPF Corona National Psoriasis Patient Registry site. Not sure if they are? Ask. If they're not, encourage them to join. The LIGHT study is a real-world research study that compares the effectiveness of home versus office-based UVB phototherapy treatment of psoriasis. Entry criteria for the study are simple. You must be 12 or older, have plaque or guttate psoriasis, and be a candidate for office or home phototherapy. There is no washout of topical, oral, or biologic medication, and the study is designed to be easily incorporated into routine patient care. It is also unique because it includes equal representation of all skin phototypes. Citizen Scientist is a platform where you, as a patient, answer survey questions, which you and researchers can analyze for trends and new insights. Citizen Scientist is currently being revitalized for greater community benefit. The NPF Annual Survey is a data collection effort the Foundation has conducted for 2 decades. This important research, conducted each fall, provides insight into the lived experience of individuals with psoriasis, including quality of life and unmet needs. If you are contacted about this annual survey, we'd appreciate you sharing your experiences with us. To achieve the Foundation's goal as mentioned, please support our mission through donations or by participating in virtual Team NPF events such as Stamp Out Psoriasis, Walk, or Cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, where you'll learn more about the AAD NPF Guidelines of Care for the Management and Treatment of Psoriasis with Topical Therapy and Alternative Medicine, what the guidelines mean to you as a patient, how the guidelines offer evidence for the treatment of psoriasis with topical agents and alternative medicine, as well as the assessment of severity of disease. You'll also learn about the impact of such guidelines on discussions with your healthcare provider and resources to help gain a better understanding of psoriatic disease and available treatment options. Now I'd like to introduce you to our speaker, dermatologist Dr. Laura Ferris. Dr. Ferris is Associate Professor at the University of Pittsburgh Department of Dermatology and Clinical and Translational Science Institute, where she practices general medical dermatology with a special focus on skin cancer and psoriasis. Dr. Ferris is also the Director of Clinical Trials for the University of Pittsburgh Medical Center Department of Dermatology and has served as a principal investigator on more than 30 clinical trials in dermatology, primarily in the area of new treatments for psoriasis. Dr. Ferris has been an invited speaker at several national and international meetings and has published more than 60 book chapters and articles in the peer-reviewed literature. She is also a professional member of the National Psoriasis Foundation and a member of the Corona National Psoriasis Registry, as mentioned earlier. It's my pleasure to welcome Dr. Ferris, who will present today's webinar, Managing and Treating Psoriasis with Topical Therapy. Please welcome Dr. Ferris.
Thank you, Bev. So I'm delighted to be able to talk to you all virtually about psoriasis and one of the mainstays of our treatment, which is topical therapy. These are my disclosures, and these are most of these are related to the clinical trials that we're taking part in. Okay, so we're going to talk about the AAD, and AAD is the American Academy of Dermatology, National Psoriasis Foundation guidelines for managing psoriasis. We're going to specifically talk tonight about topical therapy. These guidelines are really sort of helpful information that are put together by a panel of experts and that help guide dermatologists in managing patients with psoriasis. So they run the gamut from things like treating with topicals, also treating with some of the biologics and phototherapy that we've mentioned earlier, and then also thinking about things like the conditions that patients with psoriasis are at risk of, like heart disease. So these are the topical guidelines, and this sort of gives a list of what we're going to talk about. So we'll talk about a lot of the topical medications, how we use them both alone and with other medications. These guidelines also address things like alternative medicine and how we measure psoriasis severity. So topicals are generally used for patients with mild psoriasis. So we would classify that as patients who have less than 3% or 3 handprints of psoriasis on their body. Now, we mentioned that that's sort of the primary therapy, that at least what we go to first for patients with mild disease. However, we do certainly use topical therapy in patients who have moderate and even severe disease, but generally then we're using it together with another systemic therapy. One of the concepts I wanted to talk about first is a vehicle. So a vehicle is the form that your topical medication would come in. So I'm going to go through these, and many of you who have used topical therapies probably have your own opinions on vehicles. Patients tend to really like or really hate some of these. So creams are, a cream is what you would think of as generally white in color, and it's usually a little more solid. So a lotion would be sort of the liquid form. A cream would be, if you were buying a moisturizer, what you'd have in the jar, and you might need to scoop it out with your hands. In psoriasis medications, it's often in a tube and that you would squeeze out. It's white in color. It's less greasy. It is somewhat moisturizing. These can sometimes cause very mild burning or stinging when they're applied. Patients like these because they're good on most areas of skin. They do contain preservatives, so this is not a problem for most patients. Some patients who happen to have allergies to some preservatives may react to certain topical steroids. It's generally not a problem with psoriasis. Sometimes it can be a problem with things like eczema. Ointments are greasy. They have the consistency of petroleum jelly or Vaseline. We like these because they really help medication to penetrate. They don't burn. They don't have preservatives in them. The downside is that they're greasy. So you can imagine if you're trying to put on your nice clothing, if you smeared Vaseline all over you and then put them on, you might not like what that does to your clothing. So they are highly effective. Sometimes I'll tell patients because they work well, just use it at night and wear your old pajamas. Gels are what you would think of as the consistency of like a hair gel. They're not greasy. They do have more alcohol in them, so they do tend to burn a little bit more when they're applied. So I will sometimes give these to patients who really don't like feeling any greasiness on their skin because this will dry. You can also use it like a hair gel. You can use it on your scalp. So if you have scalp psoriasis, sometimes I'll have patients try a gel, but you can certainly use it on the skin as well. Solutions are liquids. So these are alcohol based. They do tend to burn a little bit, but the alcohol means that the vehicle sort of evaporates off. So again, these are ways to not have a greasy, heavy, or staining medication. So these are good for the scalp because you can just put it in a dropper bottle and squeeze it onto the scalp. You can also put it into a spray bottle and you can use that to spray onto the scalp or onto the skin. These can also be used for areas of the skin that maybe have more hair on them. Oil, there are some oil-based medications, generally topical steroids. Oftentimes they're in a peanut oil base, which I mentioned just because if you had a severe peanut allergy, you'd want to make sure you looked into that. But the reason that we like these is that the oil can be placed on the scalp at bedtime. You can sleep overnight, and the oil helps lift off scales. So an old-time remedy for cradle cap in babies was to put olive oil on their scalp at night, and that's because it lifts away the scale, and it can do the same thing with psoriasis. Foams can also be used. These are like a mousse, like a hair mousse. They tend to be less greasy. Some are a little more emollient or moisturizing than others. They're very easy to spread. So like a hair mousse, this is something that we use for scalp psoriasis. Also, some patients who have a lot of body hair find that a foam is much easier to place on their skin than something like an ointment, for example. The one I don't have in here is shampoos. There are some shampoos that can be used. Shampoos are good, again, for scalp disease. I think that they can be used to help lift some of the scale, to give a little bit of therapy. The thing about a shampoo is, of course, it does wash away. But again, that's another helpful treatment for scalp disease. So we'll talk about the topical agents. So probably the mainstay that we have are topical corticosteroids. So really key in localized psoriasis, also key in the stubborn spots that might be left when a patient's treated with systemic therapy like a pill or a shot. These are anti-inflammatory and anti-proliferative and immunosuppressive. So meaning that they help to calm down the proteins that are made in the skin that mediate inflammation. They also help anti-proliferative, meaning they slow down the proliferation of the skin. So psoriasis, when we look at the keratinocytes or the skin cells, they get made and mature at a very quick rate in the skin in patients with psoriasis, sort of slow down that activity. And then immunosuppressive, meaning that you have an overactive immune system in the areas of psoriasis, and it helps to bring that down a little bit. They are generally safe and effective, certainly when they're used for short periods of time, like 2 to 4 weeks. And that's generally the endpoint that we've used in clinical trials. So particularly with a very strong or high potency steroid, even using it a couple weeks can really make a big difference. So does this mean you have to stop using your steroid after 2 or 4 weeks? It does not. It just means that we want to think about how we use it and maybe take breaks. So a lot of times I'll tell my patients, only use your steroid on your active disease. Don't use it if your skin is cleared. You stop putting on the steroid, and take a break on the weekend. So getting, for example, 5 days of drug and then 2 days off, it can be helpful too. So when we talk about steroid potency, we classify them in 7 classifications, class 1 through class 7. So class 1 are these ultra high potency topical steroids, and the low in class 6 and 7 are particularly low. So how do we choose which potency to use? Well, it depends on how thick or severe the disease is, where we're using it, and the age of the patient. So for example, sometimes with very young children, we want to avoid some of the strongest topical steroids. So for the low potency class 6 or 7 steroids, these are what we might use on the face, in intertriginous areas. So those are areas where 2 skin surfaces touch, so things like the armpit or the groin. Also in areas like intertriginous areas that are prone to steroid atrophy or sort of a thinning of the skin, we don't want to use super potent steroids. And we can also sometimes use these on some of these difficult to treat areas, like for example, the genitalia. Mid-potency steroids are often used as initial therapy, and then the high potency can be used really for those most persistent, stubborn plaques. So when we look at how well topical steroids work alone, their efficacy can be, if we look at what percentage of patients will be nearly clear or nearly clear, we'll see that it may vary between 70 to upwards of 90%. Again, these studies are really done using the steroid in limited areas, however. Steroid can also be injected into thick or stubborn plaques. So if a patient has one spot on the elbow, let's say, that just never seems to go away, we can actually inject steroid in there, and sometimes that can clear up a plaque that wasn't responding to creams, for example. It's also been done on areas such as the nails. Nail psoriasis can be tough to treat topically, but it's not particularly comfortable, but there are injections of steroids that can be done around the nails for nail psoriasis. And so studies with psoriasis patients have shown that these high potency steroids twice a day up to 4 weeks is safe with minimal risk of skin atrophy or thinning. And why is that? This is really true, particularly of psoriasis. This is a disease where the skin is thicker anyway. We actually want that effect of thinning out the plaque. These are some examples of potent to super potent steroids. So you can see the brand names and the generic names. A lot of dermatologists sort of have their go-to. I like to use clobetasol. It's very strong, and it comes in a lotion, a spray, a shampoo, a cream, a foam. We can mix it with other things and spray it on the scalp, but you'll also see things like halobetasol, particularly in some of the combination treatments for psoriasis. So common side effects, we talked about the thinning of the skin and striae, which are stretch marks. So sometimes if I see a patient who has been given ultra high potency steroids for years as their only psoriasis therapy, I'll see that their legs or thighs, for example, or their arms have tons of stretch marks, and that comes from overusing topical steroids. You can also get inflammation of hair follicles, which is called folliculitis, purpura, which are basically it's bruising, but it can look like kind of red splotches under the skin, particularly patients who are, older than about 60. So if you have sun damage, thinning skin from the sun, and you put on high potency steroid, we can see this bruising. The greatest risk is really with using these really strong high potency steroids, and particularly over a large body surface area. There is some risk, and this is a little debatable, of something called tachyphylaxis, which is where the drug was working for you, but it just stops. And one thought is that this might come from continuously using that topical steroid for an extended period. And it is thought that taking breaks, maybe it's a week on, a week off, or maybe it's even just taking 2 days off a week, can help to reduce that from happening. These are safe to use in pregnancy, particularly in limited body surface areas. Calcineurin inhibitors, there are two drugs that are out there called tacrolimus and pimecrolimus. So these are non-steroids, but they're anti-inflammatory. These are actually not FDA approved for psoriasis, but they are for atopic dermatitis or eczema. So this can be helpful in these thinner, more sensitive areas of skin, like the face or the armpits, for example. So we have studies that show that they do help. They are helpful in treating psoriasis in these areas, but they're not always easy to get through insurance. Sometimes also these creams do cause some burning or itching when they're applied. They carry a black box warning for lymphoma. This has been pretty well studied, and when it's used in the cream form topically, even in patients with eczema who are using it on a large area, we don't see the risk of lymphoma actually when we use it. There are oral forms of these medications that can carry risks of lymphoma. vitamin D analogs. So these are vitamin D has this anti-inflammatory effect if it's used topically. So there are two drugs, calcipotriene or calcitriol. Dovanex is the brand name of calcipotriene, Vectical of calcitriol. And so you can use it alone, but we generally use this together with a topical steroid. So this can help to reduce the amount of steroid that you're using. The side effects of these are very minimal. They don't cause things like skin thinning or stretch marks. In theory, they could cause you to have elevated calcium. So vitamin D helps you to increases your calcium. That's why we give calcium and vitamin D together and we're supplementing. It takes a lot of these creams to be able to get so much vitamin D in your system that your calcium goes up. But theoretically, that is a risk. It's generally not something that we have a big problem with. So these can be used together with steroids to reduce the amount of steroid that you're using. The side effects of the vitamin D analogs are usually, they're more discomfort side effects. So they can kind of cause some burning, some redness. They can cause some people to feel itchy, but in general, they're pretty well tolerated, and those side effects go away if you stop. It is safe to use these in pregnancy and in lactation. We generally, we do not recommend that you use it before going, if you're doing phototherapy, before going in the light booth. You can do it after though. Retinoids are another class of drug. There's one called tazarotene or Tazarac that's approved for the treatment of psoriasis. Again, it's anti-inflammatory. It also helps to thin out plaques, and it can be used on the palms, the sole. It can be used around the nails. It can be used together with phototherapy. It can be used together with high potency topical steroids. The main side effect of tazarotene is redness and irritation, and sometimes itchiness. And so because the steroids are more soothing, a lot of times there are new combination medications that combine a high potency steroid together with the retinoid to try to get the beneficial effects of both. Pregnant women or women who are potentially going to be pregnant should not use tazarotene. While the absorption of it's minimal, retinoids can cause birth defects. And then just plain old moisturizers. So having dry skin will make psoriasis worse. So using things like creams, lotions, gels, particularly in the winter, making sure your skin doesn't get dry. There's other topical agents. So salicylic acid is available. You can buy these over the counter or they can be prescribed in higher concentrations. So salicylic acid is really good at minimizing the scale or softening the plaques and helping to thin out. And really the reason I like salicylic acid is that it helps your other medications penetrate better. So if you do some salicylic acid and then you put on your topical steroid, with less scale, your topical steroid is going to penetrate better. There is a risk of getting toxicity or salicylism. It's recommended not to have patients use these over huge body surface areas at high concentrations, particularly if they have kidney or liver disease. You also don't want to put this before going into a phototherapy booth. But this can be helpful. There are over-the-counter products that have salicylic acid in them. There's a moisturizer called CeraVe. They make a CeraVe called SA or salicylic acid. There's also CeraVe Psoriasis, if you look at that, and that has salicylic acid in it. So those are just, I mentioned them not because they're any better than any other moisturizer, but just because that's a way to find it easily at your drugstore. Anthralin is another topical medication that can help to reduce the activity of T cells, which is one of the inflammatory cells that causes psoriasis. They've been studied for sort of 2 to 3 month time periods to help treat mild psoriasis. You can also use it together with lights. So there are studies that show that if you do anthralin and then excimer laser, that can be helpful. And this can cause some staining of the skin, that along with coal tar, which is a similar topical. So coal tar also decreases the skin turnover and the inflammatory cytokines. Coal tar can be used together with light therapy. An old treatment was Geckerman therapy, where patients would be kind of soaked and smeared in coal tar and then wash that off and then go into a light booth. That can be very effective at clearing psoriasis. It just it smells pretty bad and it can stain your clothing in your bathtub. So we don't use these quite as much, and you don't want to use coal tar in pregnancy. So the other thing is that, as I mentioned, topical therapy doesn't have to be used alone. We'll do this with, for example, biologic or an oral medication for psoriasis, and that's particularly for patients with more severe disease. So there are different studies that have looked at this: methotrexate, cyclosporin, acitretin, or which is psoriatine, which is an oral retinoid. All of these drugs have been studied combined with other topicals. And we know that it's not just these drugs, it's also all the biologics and other drugs like that that can be combined with a topical medication. So there's also the drugs that are in the pipeline or things being developed. And this is why I really like doing clinical trials, is we get a chance to see these in action before they're available. So one is roflumilast. This is it works against an enzyme called phosphodiesterase 4 or PDE4. And PDE4 is involved in the production of multiple inflammatory cytokines or proteins. And so we have there's an oral drug called Otezla that also works to block PDE4, but this is basically a cream that does that. And so there have been various clinical trials published recently. And so, one of the ones that was recently published, they found that they looked at the patients who saw their skin clear or almost clear, and that was about a little over a third of patients, or around a third of patients had their skin clear or almost clear if they were on one of the active drug versus only about 16% in the placebo group. And really the nice thing about this was that there was no skin irritation. There was no skin thinning, none of those risks that we can see with topical steroids. What's really interesting is that while the 38% is pretty good, when you looked at areas like the armpit, the groin, the inverse psoriasis, more than 90% of those treated with the highest concentration of drug that was tested achieved clear or almost clear skin. So armpits can be tough, it's irritating. We don't want to use a high potency topical steroid because it can cause skin thinning. So a drug like this that can be effective without being something that we want to avoid in these areas is great. Tapinarof is another topical steroid. It modulates something called the aryl hydrocarbon receptor. So this is an antioxidant, and it decreases these inflammatory proteins. In the most recently published studies, we found that 65% of patients who were treated twice a day with the highest concentration of drug were clear or almost clear, whereas only 11% of placebo treated. And if we looked at how many patients had a 90% reduction in their psoriasis severity, it was 39% in the drug, but none in the placebo. So really showing that this, again, looks like another promising topical treatment. There was some mild skin irritation in some patients, but other than that, this was well tolerated. So this is exciting to think that we might have new non-steroid, non-vitamin D topical therapies available soon. So the other thing I want to mention is this combination topical therapy. So we can think of combination therapy as a shot and a cream or a pill and a cream, but there's also just combining two different creams. So calcipotriene together with a vitamin D analog, so a calcipotriene together with a high potency steroid like betamethasone, halobetazole, a strong steroid with tazarotene, the Tazorac, the retinoid. There's also one that's available that combines clobetasol, zinc pyrethione, and salicylic acid into a spray. Your dermatologist may custom compound others. So, for example, I like that clobetasol, zinc, salicylic acid. I have a compounding pharmacy. They'll mix it for me and put it into a spray bottle for the scalp, and my patients have been pretty happy with that. The reason we like to combine is it can increase the efficacy. You get 2 medications worth of activity, but only the time spent of applying one. So these are all together in one cream. So patients find these to be helpful. Okay, I'm going to mention alternative medicine here too. So what is alternative medicine? This is sort of a broad category of products or practices that may have healing effects. These are often originated outside of Western medicine. These may be things that come from other cultures. And the thought is that, we used to maybe in medicine write off these things and say, that's, there's no science behind it. So there's really been a push to say, well, maybe if a lot of people have found that this works, we should consider studying this to see. So we can give our patients options other than drugs. And so there has been a push to better understand alternative medicines for all kinds of diseases, including psoriasis. So traditional Chinese medicine is commonly used in China for patients with psoriasis. This can include herbs or given topically or orally, acupuncture and other therapies. So one of the kind of downsides of sometimes things like traditional medicines is that if I say I'm giving you a tube of clobetasol, I know that that has exactly 0.05% of the medication in it. I know it's made under standardized conditions, but something like indigo naturalis, it's hard to have a standardized formulation and concentration of that. So you want to make sure that if you're seeing somebody or doing this, that you are going to somebody who knows what they're doing and you're not just, for example, ordering this off the internet. This also makes it hard sometimes to do clinical trials because you need to have a standard formulation so that everybody in the study is getting the same thing. We also don't have good pregnancy data on some of these herbs, so it's recommended not to do them during pregnancy. Acupuncture has been shown to maybe have some minor efficacy for things like mild to moderate psoriasis, but it probably has a little more data for use in other areas than psoriasis. Aloe vera can be used topically, so it's a soothing plant-based gel. St. John's wort has been reported to improve mild psoriasis, but it's not terribly well studied. Omega-3 or fish oil has been suggested to have anti-inflammatory effects as well. And then vitamin D supplementation is interesting because I talked to you about topical vitamin D like calcipotriene, and while that works for psoriasis, my patients will often say, well, how about if I take it orally? It seems like if it works in a cream, that should work really well if I take it orally. And it turns out it actually doesn't improve disease activity. It's actually not recommended for the treatment of psoriasis. Curcumin is an interesting one. It's an active ingredient in turmeric. There has actually been a clinical trial that used it together with topical steroid and showed that it may improve the response, the severity of psoriasis, particularly when used together with topical steroid. Zinc, so people ask about zinc, a lot of interest in zinc. That has not been shown to be helpful. And then a gluten-free diet is kind of all the rage right now for lots of stuff. And there are some patients who have true gluten sensitivity and celiac disease. And for those patients, gluten-free diet may help. For the average patient who doesn't have something like gluten sensitivity or celiac disease, there's no evidence that it works. And then, of course, stress reduction. So anything that reduces stress can certainly have a positive impact. I see all the time when my patients have a really stressful time in their life, it's very common that their psoriasis will flare. So stress reduction does help. Okay, now I'm going to talk a little bit about psoriasis severity. So I mentioned body surface area and that a handprint is considered 1%. Why is this important? Well, we use things like the body surface area in clinical trials to decide who has severe enough psoriasis to go into a study. And we also use it to say, how much did your body surface area go down? We also use it for something called treat to target. And so this is a way that most people can measure a handprint pretty easily on the patient. And so the target is that after 3 months, if you start a new therapy in a patient, after 3 months, your goal is that that patient should have one or less handprint on their body. Now, if they have maybe you started with terrible psoriasis over 80% of your body and you're down to 3%, you're happy, that's fine too. So it's okay if we say try to get at least a 3% or even like a 75% improvement. And then 1%, we then want to see patients after that first 3 months, about every 6 months to make sure that they're staying at that 1% target or lower. There's other things that we use. There's something called the PASI, the Psoriasis Area and Severity Index, that looks at not just how much of your body is involved, but how red, how thick, and how scaly is your involvement. The PGA is your physician's global assessment that we say overall, I think you've got mild, moderate, or severe disease. Sometimes we will take those two together to say how much psoriasis is there and how red, thick, and scaly is that. That's sort of multiplying the PGA times the body surface area. And then we also like things called patient-reported outcomes. So it doesn't matter if I think your psoriasis looks better. What really matters is, do you feel like your psoriasis is better? Is your treatment working for you because now you do things you wouldn't do? Is your quality of life improved? Are you not itching anymore? Are you not spending 15 minutes vacuuming scale off your floor? So these are the kind of things that are important. And so these are other ways that we measure psoriasis severity too. What do these treatment guidelines mean to you? Why does the American Academy of Dermatology and the National Psoriasis Foundation put in the time and the money and the effort to do this? We want to be delivering, evidence-based care, and we want to be able to know the right treatment for the right patient at the right time. When these guidelines are made, there's patient input here too. So that's very important. And we want to be able to also be able to give guidance. So for example, the primary care physicians and education on, what kind of things they should be looking at in their psoriasis patients. In conclusion, there's not one measure that completely determines your quality of life. What's important to you might not be important to somebody else with psoriasis. So that's why talking to your physician and for us dermatologists, talking to our patients is really important. There's also other things that we look at when we're making a treatment choice together. Is what's your goal of treatment? Is the idea of having a shot just absolutely unacceptable to you? How do you feel about blood work? What's your tolerance for risk of your treatment? And so that's why really I firmly believe that treatment is a shared decision. So we are there to give you the options. We're there to talk about what is a potentially good and what's a potentially not so good option for you. It's important to me that my patients give me their input as well. And now we're ready for the question and answer session.
Well, thank you, Dr. Ferris, for your presentation and providing such an informative look at the guidelines for use of topicals and alternative medicine. As you mentioned, it's now time for the Q&A. So our first question, what are topical options for fingernail and other psoriasis on the legs?
So fingernails are really tough, I will say, to treat topically. If your fingernails are really severely involved, I oftentimes will say we really need to think about a systemic. But there's some data suggesting that topical steroids can help. One important factor is that even though your nail is what you see, that nail plate, your fingernail itself, that's kind of dead material. And what you're seeing is the impact of what's going on in what we call the nail fold. So that's sort of like along your cuticle. So when you treat with the topical, you're not putting it right on the nail plate. You're putting it right along that skin at the base of the nail. So topical steroids can be used. Also topical retinoids. We don't have specific clinical trials, but something like a combination topical steroid, topical retinoid can be used there. You can do injections of steroid. It's awfully painful to get an injection along all 10 of your fingernails, but the steroid can be injected into that nail base as well. There's some evidence for doing things like light treatment, particularly with laser. But that's generally sort of the nail. And then legs, legs are an area that I would use generally a high potency topical steroid, so you don't have to deal with things like the skin folds, like the armpits. So something like a clobetasol or halobetazol, maybe together with a calcipotriene.
And which is more important, trying to loosen the existing scales or trying to stop new ones from forming?
So that's a great question. I think that they're actually both important. So that's why, I mentioned salicylic acid. So I like things that have salicylic acid because I think loosening that existing scale, one, it's nice not to have your skin flaking off. So just being rid of it is in and of itself is nice. But two, the reason we like to loosen it is so that your other medications like your topical steroid can then penetrate better. Stopping new areas from forming, I will say topical medications are good at treating stuff that comes up. They're not really good at preventing new stuff from coming up. So that's generally something that has to be done internally. So that's using like a pill or a shot, or maybe a light, phototherapy as well.
Question coming in tonight. Because calcipotriene does not cause skin thinning, can it be used on the face?
Yes, calcipotriene can be used on the face safely.
And what type of topical treatment do you recommend for the hands and feet?
So I'm assuming you mean like the palms and the soles. So those are thicker skin. So there's one, because that skin is thicker, we definitely want to go with a higher potency topical steroid. So that's an area where I'll use something like clobetasol. Two, because oftentimes that skin does get thickened, that is another area where I do like patients to do some salicylic acid. So for example, I may say use a moisturizer with salicylic acid every morning to help loosen some of that thickened skin. And then at bedtime, you can put on your clobetasol, something more high potency. You can even do what we call under occlusion, which means if you have something like even just like socks over your feet, that warmth will help it to penetrate. Some patients will even, for a short term, try to put something like plastic baggies or cotton gloves on their hands and feet. That can help your medication penetrate better. And again, the risk of things like stretch marks and skin thinning really is not an issue for areas like the palms and soles.
And what is the best topical for plaque psoriasis? What causes flares?
So for plaque psoriasis, again, plaque psoriasis as opposed to something like guttate psoriasis, plaque psoriasis is usually thicker. And so that is where, again, the higher potency steroids can be used, something like clobetasol. If you have very thin plaques of psoriasis, I will sometimes go with a more medium potency steroid, something like triamcinolone is usually very accessible to patients. It's inexpensive and available widely. But all of these drugs that we're looking at are that we talked about really were primarily tested in plaque psoriasis. So there's all of these. And in terms of what causes flares, it's usually not topical medicines that cause flares. It's usually things like stress or maybe illness. So sometimes if you get things like a sore throat or if you have a viral infection, that can flare up psoriasis.
And why does the skin turn white if you use topicals regularly? Is there a topical option that works that doesn't lighten the skin?
So that's a great question. So there's sort of two reasons why we see whitening of the skin. So one is sometimes we have what we call vasoconstriction. So steroids, their potency is actually tested by how much they vasoconstrict or make the little blood vessels in the skin clamp down. So when we see that, that's usually, if you look at somebody with a light skin tone, if you put a really high potency steroid on, you may see that skin goes white. So it may go from a normal pink color down to white, and that's temporary, and that is from the vasoconstriction. The other thing that we see, however, and particularly in patients with darker skin tones, is that you can actually get lightening. So it can help, the steroids can kill off the pigment producing cells, and so you actually will get white areas of skin. So this is particularly a problem for patients with darker skin tones. This is a reason why, sometimes when I have patients with darker skin, I'll try to avoid that by using more of a medium potency steroid or using another topical. So steroids definitely lighten skin. In fact, there are places in the world where we do not sell things like clobetasol over the counter because it does have side effects. So we want to make sure that those are used under a physician's guidance. There are places in the world though where you can get medications like clobetasol over the counter, and they are actually sold sometimes as skin lightening creams because of this fact that they decrease the pigment. It's not safe, particularly if you're using them on areas like the face. High potency steroid, like near the eyelids, can be a problem. It can cause glaucoma, but that is unfortunately a side effect of topical steroids.
And what topicals work well for scalp psoriasis? Is light therapy an option?
So the topicals that work well are, a lot of it comes down to vehicle. So scalp is an area that can certainly tolerate stronger steroids. So drugs that I think work well are clobetasol, which can come in a liquid form, and that's one that I said sometimes I'll put into a spray bottle, or you can buy clobetasol spray. There are shampoos that can work well. So you're going to shampoo your hair anyway. The shampoos that I like are generally the ones that have either salicylic acid or coal tar in them. So those are like Neutrogena T-Gel and T-Sal are sort of two brand name ones that are easy to find. So I like that. And again, the salicylic acid helps loosen up the scale. Foam. So clobetasol comes in a foam form. And then in terms of, and then oil. So I mentioned that particularly with thicker scale, there is a medicine called Dermasmooth that has it has steroid and an oil base that can be applied to the scalp. Light therapy can be done. It's tricky, particularly with somebody who has thick hair. You can do things like laser, but it's very excimer laser. That's very time consuming. There are light combs that you can buy. You can usually just buy them, on the internet. They don't have the kind of strong clinical data, but basically take it. It's a comb. You plug it in and you comb through your hair. So I have had patients who have used them and liked them. I can't really speak to data in large groups of patients talking about how well they work, however.
And how long can you safely use topical treatments?
So topical treatments, the short answer on psoriasis is usually 4 weeks, but as you know, this is not a 4-week disease. And so one, if you're using this on thick, red, scaly skin, I'm not very worried about the side effects of things like skin thinning. But what I don't want patients to do is use strong topical steroids on areas that have very, very thin plaques of psoriasis, or to continue using it to try to keep the psoriasis away. So only using it on active disease is important. Trying to use the lowest potency steroid that you need. So maybe you need that clobetasol for a month. Maybe then you can step down to triamcinolone. Also taking breaks. So sometimes I'll tell patients take off the weekends, or as your psoriasis is getting better, you may only need to use it 3 times a week. So I think say going 4 weeks and stopping forever isn't feasible, but I think trying to sort of titrate down how much you use and taking breaks is really the way to use it most safely.
Another question, Tapaneroff doesn't say how long it was used for the patients that were treated.
So that was a 12-week study. So that was used for 12 weeks. There are longer terms. So I know that, there's ongoing clinical trials and there are long-term extensions that it's been used up to a year. The data that we have in terms of efficacy, we have up to about 12 weeks, but they did see improvement even as short as like 4 weeks when they looked.
And we had mentioned nail psoriasis previously. What medications or treatments have you found helpful in the treatment of nail psoriasis with onycholysis?
Yeah, so onycholysis is lifting of the nail bed away from the plate. So sometimes if somebody has psoriatic disease, either arthritis or psoriasis, you'll see that whereas, a normal healthy nail has sort of this little white band at the tip of the finger at the top, that might go back into, and you might see this white that kind of comes back back farther closer to the cuticle. And so that's onycholysis, or the nail lifting off. So what have I found helpful? In general, I find that topicals are not the most effective treatment. What I have found is, in general, what works best for the skin also tends to work well for the nails. So, for example, drugs like methotrexate or acitretin, the biologics, most of the biologics have pretty good data where they've actually studied how well it works for the nail, and it seems to work for all kinds of nail psoriasis. So onycholysis is one. Sometimes people get yellow or oil colored spots. It also will work for that. And then another really common finding in the nails is pitting, where it looks like you've got teeny little pinpoint divots in the nail. All of those can be improved with, the biologics probably have the best data just because it's been studied more, not because they work better than anything else. So all of those things can be improved. Another thing I would point out is a treatment for nail psoriasis. Like I said, you put it at the base by the cuticle if you're using topical therapy. And the reason is, when we're treating, the goal is that the new nail growing in is healthy. So the nail, if you've got pits or onycholysis, you're really not going to improve the existing nail. What you're trying to do is stop the process so that the new nail growing in is healthy. So if you look at studies of how something works for nail psoriasis, you'll never see a 4-week study. You'll always see at least a 6-month, because we need to give that nail time for healthy nail to grow in, and that's what we're looking for in terms of improvement. So nothing will work quickly. Goal is to let healthy nail grow in.
That's very good to know. Interesting. Thank you, Dr. Ferris, for taking time to answer the many questions we received for today's webinar, and for sharing your expertise about the use of topicals with today's participants.
Well, thank you for having me tonight, and thanks for all that the NPF does for physicians and patients to help us take care of this disease better.
Thank you. In addition to today's webinar, podcasts about the guidelines are also available as listed on the screen through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can access podcasts at the website listed here. If you'd like more information about other treatment guidelines, you can catch Dr. Ken Gordon discussing systemic non-biologics in episode number 80, or biologics with Dr. Alan Mentor in podcast number 36. Contact the Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. If you still have questions, would like additional information about treatment options, need help finding a physician, or are having issues with accessing treatment, contact our Patient Navigation Center by phone or email as indicated on the screen. You can also contact the Navigation Center to ask about connecting with others who have psoriatic disease through our one-to-one program, which offers trained volunteers who have a connection to the disease. Reach out at education@psoriasis.org or call 1-800-723-9166, option 1. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. Thank you again to our sponsors, Bausch Health Foundation, Celgene, and Novartis for their support of today's webinar, along with others in the Psoriasis Guidelines webinar series. Look for the next guideline discussion about systemic non-biologics to occur on October 15th with dermatologist and rheumatologist Dr. Alice Gottlieb. Finally, you can access our webcast archive at psoriasis.org/watch-and-listen. This concludes our presentation for today. Thank you for attending.